Whoa, that's high for me. Good evening. I'm Mary Lou Hayden, a member of the Miracle of Living Committee. And I welcome, you can't hear me? Now? Closer? Whoa. Okay. Hi, I'm Mary Lou Hayden. I'm a member of the committee who helps plan these programs for you. And tonight, we're going to hear from our panel on pain management and opioid abuse and addiction. First of all, I'm to take care of the housekeeping. Over to my right in the back, as you go to the right, that's where the restrooms are. There are also fountains there, water fountains. If you have cell phones on, please, if you have those watches that have cell phones, or you have a cell phone in your pocket or purse, please turn off the ringer, put it to vibrate, turn it off so it doesn't interrupt our speakers. If you need hearing aids, they're available at the back desk where Mary is sitting. I've already told you where the restrooms are. These programs are recorded live, so you can buy them if you want. You can get a DVD for $15, or on Monday, you can go to the West Tower at 10 o'clock, and you can watch the video presentation. And if you find that this is really a good one and you would like to watch it again, come, or it's also streamed. So within a couple of weeks, it'll be on our streaming. Tonight, of course, it's being streamed live, but you're here, so you'll be able to ask questions. About questions, you cannot ask them from the floor because we wouldn't be able to hear them on the recording. So you have to wait until we've written questions are collected by the members of the Miracle of Living Committee. We have paper and pencils for you if you didn't bring any, and we will be glad to take your questions. The replay is this coming Monday at 10 o'clock. Reservations aren't required, but it would be nice to know how many people are coming, and tell your friends and neighbors if you think that they might be interested in seeing it quickly. Okay, after our last speaker, there are 3 speakers tonight, we have a short break. And during that time, the members of the Miracle of Living Committee will be picking up your questions that you're writing, and our speakers will have a chance to relax a little bit, and you can go over and get some water and coffee, and if there's anything else there. Okay, now one other thing at the close of the program, after you've heard everything, please fill out the evaluation form that came with your packet. You all have a packet, don't you? Because if you don't, go back and get one, because it's important. But fill out that evaluation form because it tells us next year what kind of programs you would like to have. And please let us know how you feel about our programs. Thank you.
Thank you for your attendance this evening. My name is Dr. Tammy Ginder, and I will be the moderator for this evening presentation. And it's my pleasure to introduce our first speaker. Dr. Kartik Ananth achieved board certification in programs designated with the prestigious Accreditation Council for Graduate Medical Education. His previous residency certification in psychiatry from Westchester Medical Center at New York Medical College. It makes him one of 55 physicians in the United States to hold double board certifications in both pain management and psychiatry. Dr. Ananth completed his residency training in psychiatry from Westchester Medical Center at New York's Medical College, and his pain management fellowship was completed from the prestigious USC Keck School of Medicine Department of Anesthesia, which providing him with a unique experience and sophisticated training in the evaluation and treatment of pain. As a psychiatrist and pain specialist, Dr. Ananth provides comprehensive and individualized psychiatric care and pain management treatment at the Pacific Pain and Wellness Group in Torrance, an environment that is conducive to recovery and healing. With a compassionate and excellent bedside manner, Dr. Ananth's multidisciplinary approach to psychiatry care and pain management allows him to work with various specialists such as anesthesiologists, oncologists, neurologists, orthopedic surgeons, psychologists, acupuncturists, and others, and a treatment of wide spectrum pain disorders. The field of pain management is continually advancing, and Dr. Ananth remains at the forefront for new pain treatments and modalities to help patients control their pain. One of the cutting-edge procedures that Dr. Ananth uses is transcranial magnetic stimulation, also known as TMS, a non-invasive method of activating certain brain areas that are linked to pain relief. Dr. Ananth is also a member of numerous medical organizations, including American Society of Interventional Pain Physicians, American Academy of Pain Medicine, International Association for the Study of Pain, and American Psychiatric Association. Please join me as we invite Dr. Kartik Ananth to the stage.
Thank you. I think I need to update my biography. So now I think there's probably somewhere around 100 double board trained physicians who have psychiatry and pain management. That probably was off my website, which was about 7 years ago or more. So we can't, it's not interactive, right? No, so go through it and then, okay. As I go through this, I'm going to skip through certain slides. I mean, I think I want to get the general message across of what opioids are, how we got to where we are, and maybe a few different techniques of how we're going to get through it. And then there are a couple gaps in the talk where I'll probably add some things that aren't here in the slides. And then there's also some overlap in what we're talking about, so we can ask a lot of questions later and perhaps answer things that way. That said, my running through this will probably be a little bit shorter than you might expect. I want to start doing TMS again. Actually, I'm not doing it right now, but the cutting edge is probably spinal cord stimulation, which is what we do there. All right. All right, well, how did we get where we are? You see it and you hear it in the news every day, opioid deaths, opioid prescriptions, doctors going to jail for writing too many opiates. So how did we get here? Well, I think it's really important to look at the economics of the situation. We have to remember, and this is crucial, that wars have been fought over opioids. I mean, we think back to the 1800s and the opium wars. You see all the protests going on in Hong Kong? Well, Hong Kong used to be part of China, and they had to cede Hong Kong because of the opium wars. So opioids are nothing new in the world. They have their effects, they have their addictions, and they make people a lot of money. A lot of times it's really simple to conceptualize a lot of the problems we have in society, especially if we start to look at things in terms of, follow the money. Opioids became, written profusely in the 80s and 90s because of advertising and the changing of the pain scales to going to the pain being the fifth vital sign. And a lot of revenue was produced for a lot of companies because of opioids. I'll get into that a little bit more. Basic structures of opioids. Opioids are in a couple different classes, but the major ones are the phenanthrines and the non-phenanthrines. That's a little bit complicated, but I'll get to where it's applicable later. They stimulate some really important receptors in our brain, being the mu, kappa, and delta receptors. And when they stimulate them, they cause a cascade of messengers to be released, which in many people make them not feel much pain or sensation. In some people, they make them less depressed, less anxious. In other people, they just make them plain high. In other people, they make them throw up profusely and never want to take the stuff ever. So it affects people differently, but what we're seeing out there are a lot of problems with when these things are given to people and it agonizes or stimulates those receptors. It puts people in a dangerous situation of where they can't breathe or they have respiratory suppression and a host of other issues which start to break down the normal physiological process. All right. Oh, here we go. So we're going to talk. So I'm going to deviate a little bit from this, but we're going to be talking about heroin and fentanyl, physiologic dangers, and what we can do. So that's heroin. Okay, there's a powder. It's melted, and it's drawn up in a syringe, and it's injected. Now, I think we can all venture a guess and say that those are probably not sterile needles. That creates another societal problem because it spreads diseases. Heroin use is on the rise. We see a lot of heroin-related overdose deaths. It's gone fivefold from 2010 to 2016, and in 2016, it shows that almost 15,000 people died from drug overdoses involving heroin. 75% of people who report being new heroin users claim that they've used opioids before as a step. So what really happens? Here's what happens. Somebody gets started on opioids. Most likely they went to the doctor. Back in the 80s and 90s, it was as simple as I have a paper cut and here is a bottle of Vicodin. Okay? And that starts the whole process. Now, the pendulum has swung the other way and it's not being given out as much. Well, what do people do? They go out and find some substitute, and a substitute that's convenient for them. There are other people in society here that know how to fill a void. Okay? Oh, you can't get your Vicodin? Well, I've got something else for you here. Try this. See how you feel. And everybody who goes into it, I can say this, and I think Mo can probably vouch for this as well. Most everyone says it's only going to be one time. I'm only going to do it this time, and I'm going to be done with it, and I'm going to kick this addiction or dependence or whatnot. It rarely ever works out that way. And it just spirals on itself, and it gets worse and worse until you have to start graduating to the next substance. And when heroin doesn't become available, or when somebody, it becomes tainted or they can't get it, they move on to other things. We have a big problem out there with fentanyl, but there's another one that's even worse. It's called carfentanil. So how does the light work? Is there oops. Here we go. Okay. So this is 2 milligrams of fentanyl right there. You see this little dot? That's carfentanil. Okay, it comes from China mostly. And just a small tiny bit of this is the amount of fentanyl you see here. This is 2 milligrams. This is 0.02 milligrams. Okay? Just for context, if I'm doing an injection in the office and we're trying to sedate somebody, we give them 100 micrograms of fentanyl. This is 2,000 micrograms right there. So this can kill someone. Whenever firefighters or a hazardous response goes into a place where they think that there's carfentanil, if they feel like they have gotten even a touch, even a tiny speck on their skin, they have to go to the emergency room immediately because they can stop breathing. Now, why is this out there? Again, economics, filling a void. That stuff probably costs about $800 in raw material, which will result in about an $800,000 to a $900,000 profit on the street. Okay? It's that much more powerful, and they figured out, well, if they can get this out there, it's cheap to make, raw materials are cheap, your profit margin is going to be super high. Now they're starting to mix all that stuff with fake pills, which is another void being filled. Okay? So they sell Norco or Vicodin, they get presses, and they make these pills. But instead of putting Vicodin in it, they try to estimate how much it would be and put in carfentanil or fentanyl. And that's how people get into trouble. And on top of that, people who are using drugs illicitly don't usually just take a pill of fentanyl or Vicodin or anything like that. What they do is they take that along with some Johnny Walker or some Jose Cuervo, and then you get that synergistic effect. And the two together can cause worse respiratory depression. So just from seeing what we have here, Carfentanil is 100 times stronger than fentanyl, and fentanyl's really strong. A lot of the patches had been prescribed for many years for a variety of things, including fibromyalgia. The real indication for fentanyl is for metastatic cancer. When you have pain that gets into the bones and is hard to control, that's when you use fentanyl. You also use fentanyl during procedures because it's quick in and out, and you can reverse it quickly. There are some sublingual formulations, but again, these are in very difficult to control types of pain. And the half-life is very quick. It's in and out of the system fast. So, I go back to drug dealer Econ 101. It's filling a void. It's all about going back to where people can make money. Fentanyl's cheap, $800 raw material, $800K in profit. Small amounts can increase profits. Easy to transport because it's just a little bit. So what we're seeing now over time as we've swung to the pendulum has swung the other way, physicians aren't prescribing as many opiates, okay? So you're seeing that there's a drop-off, in the amount of prescriptions and overdoses, all opioids overall. Okay, so over here, it's just coming down, stabilizing. But overdoses are still going up. So we go back to here and here. These things are filling that void. So this problem that started, yes, it's been around forever, but it mainly got really heavy in the 80s and 90s, and then it continued in 2000s. I did my fellowship in 2010, and we were writing large prescriptions for these things. It's only gotten to become under control, I think, within the past couple of years. So societal implications and physiological problems. Physical dependence, development of withdrawal symptoms after you stop. If you've been on it for 3-4 months, let's just say even 2 months, and you stop taking it, even if it was a low dose, you will feel something. And most likely it will not feel good. Okay, if you're taking a large dose for a long time, it's even worse. And a lot of people can't come off of it. It causes psychological dependence, craving for opioids. A lot of people used to do what we called opioid rotations. People got tolerant, so then you would rotate it to another medication. And then we started to find out that some of these medications, opioids, actually ended up causing more pain, which is another topic that we'll get into in a second. So the CDC came out with some guidelines recently on how to prescribe opioids for chronic pain. It's really common sense. I don't think that there's really anything more than just using basic common sense 101. Let's try to use the minimal amount of opioids for the minimal amount of time and use it for appropriate conditions. Somebody has surgery, somebody breaks their bone. A set small amount of opiates for a defined period of time. Let's say 2 to 3 weeks max. And that should be sufficient. And we can combine it with other types of treatments. We can combine it with certain nerve blocks, we can combine it with other types of medications, and combine what we call adjuvants, making them work better. So you can use a smaller amount of opiate with another medication mixed in and make that opiate work a little better and also get adequate pain control. So, you talk about opioid selection, dosage, duration, follow-up, discontinuation. All of this is just common sense. We all know this, okay? So, getting back to heroin, it's abuse is a larger part of the substance abuse problem, yes. I think this slide was meant to show a graduated form of how a person goes from one substance to another. So basically like a gateway phenomenon. You start with one and you graduate to the next. On here it says if you use alcohol, you're 2 times more likely to be addicted to heroin, marijuana 3 times more likely, cocaine 15 times, opioid painkillers 40 times. I don't know if I agree with all this. I told one of our interns earlier that I'm not sure if I agreed with it. I do think that this right here, for sure, I mean, you're that much more likely. Is it 40 times more? Who knows? But you're a lot more likely to get addicted to heroin. Because once you start to go through that withdrawal and you take those pills away, somebody's going to come in and try to give you this, or you're going to go looking for it. Cocaine, I don't know. So heroin overdoses, obviously we're seeing this in a lot of different states, especially in the Southwest. We're seeing it here in Arizona, Utah, Colorado, and on the eastern seaboard a little bit. You don't see too many decreases here. There's only one. Okay, synthetic heroin overdoses. You see an increase in death rates. Look along the Appalachian Valley in this way, in this area. A lot of increases here. This is even an increase too. Everything else is stable or not significant, meaning it's not really going down. Same thing here with fentanyl. I mean, it's skyrocketing in this area here. Again, look at the Appalachian Trail in this area, Midwest, and over here, good old California. It's right on our doorstep as well. So fentanyl overdoses by states. This one surprised me, actually. I didn't know this, but New Hampshire has a huge problem with it. It will go wherever the market demands it. Again, filling a void. Somebody will be there with a solution to a problem. If there's money to be made, they'll find a place to sell it, and people will die. So a lot of the fentanyl is produced in China. I mean, the raw materials to make it are not difficult to make and are relatively inexpensive. The skyrocketing overdoses, I mean, in Baltimore, look at that. I mean, it's gone up that much. Ohio, Washington, D.C., I mean, places you wouldn't really expect, but it has. So fentanyl overdoses are on the rise. It's, again, 50 to 100% more potent than morphine, illicitly manufactured. Now, here's the interesting thing, and I want to get on this a little bit. And I have seen this in the office, actually. So patient comes in, they had gone to the emergency room, they were sent to follow up with us, and in the emergency room, they tested positive for cocaine. And patient says to us, well, yes, I do drugs, but I've never done cocaine. The drug dealers are looking for different ways to make their products stand out. I think that's the best way to put it. Okay. And what they're doing is they're then mixing other things in. Okay, they're mixing cocaine in with fentanyl, with other types of opiates. They're also mixing PCP in with marijuana. They're doing all kinds of things to make their product better. Okay, here's another thing, and it goes back to the drug dealer 101. I had it in another slide, but I forgot to put it in this one. This is interesting. If you have a population wherever where they're selling narcotics, drug dealers will intentionally increase the concentrations at periods of time. It's kind of like a Kmart special, a fireside sale, Come and get it. It's the special. It's the one of a kind unique. What they want to see is that people will take these overdose and die, okay, for one particular reason. The reason is that everybody else is going to want to go in and buy that because they know that it's more potent, and they're going to get a better high out of it. It's crazy the way, I mean, we think about this, but that's what they do. So once in a while, they'll put out a batch that's a lot stronger. They will expect people to die, and they will expect to get more customers out of it. This happens. This does happen. Okay, so I wanted to get on to opioid-induced hyperalgesia. We talked about two different types of opioids. There's the phenanthrenes and there's the non-phenanthrenes. What we've seen over the past 20 years is, no matter how much of an opiate you give to somebody, sometimes their pain just gets worse, even though their physical condition appears to be getting better. And we never knew how to explain this. We were trying to figure out as a society, well, maybe they need more. Maybe we need to rotate opiates. And even when we did all of that, their pain still continued to get worse. Okay? So we came up with a centralized pain phenomenon and opioid-induced hyperalgesia, which is being studied more. We now know that certain types of opiates, which are the phenanthrenes, tend to cause inflammation around certain cells that we have in our body that surround nerves. These cells are called glial cells. When they get inflamed, they continue to irritate neurons and nerves, and that's what causes that increased pain phenomenon. We also know that if you take opioids for a long period of time, not only does your immune system get compromised, but you also become less able to deal with physical stress, and you become more sensitized to pain overall. So an example would be, you hit your finger on the wall, okay, you kind of say, ouch, and you get over it. If you've been on opiates for a long time, you feel like your finger, just got severed. It's that painful if you've been on opiates for a long time. So, and it takes a while to kind of shake that phenomenon. So we know that opioids, not only do they cause symptoms like respiratory depression, constipation, and all the other side effects, decrease in hormone levels, testosterone especially, they also cause more pain sometimes. So methadone is a type of synthetic opioid that we use to substitute. We use it to substitute using one opioid for another. So if somebody's using heroin, we're going back to the dirty needle, okay, we want to consider what's called harm reduction. Okay, we don't want patients to use things that are going to cause another problem, like injecting an infection into their bloodstream. Okay, so what we do is we substitute it for a medication like methadone or Suboxone, which we know is used at a stable dosage and is also produced in a pharmaceutical lab, is clean. And so basically that patient can go back to their regular life without having to worry every day about how they're going to find medication and then get involved in the behaviors that are associated with looking for drugs. Now, here's the thing with methadone. It has its own issues. It can cause problems for the heart. It's called QT prolongation. It's very difficult to taper off of. So basically, you're substituting one problem for another problem. The second problem tends to be a little bit safer than the first, but it's still a problem. And now the dealers on the street are now starting to mix methadone with other drugs like methadone and cocaine, and they're mixing it with heroin too. They're mixing it with Adderall, all kinds of stuff. So ultra low dose naltrexone is an interesting drug. This is not an opiate. In fact, it's the drug that we use to treat opioid overdoses. So there's a drug called naloxone. Naltrexone is related to it. So somebody has, let's say, an opioid overdose. They come to the emergency room. They get an IV of naloxone. Okay. Well, what we found is that when we're talking about opioid-induced hyperalgesia, naltrexone, which is similar to naloxone, but you can swallow in a pill, actually reverses some of that opioid-induced hyperalgesia and makes the opioids work better. And you can give it at a really low dose, and when you give it at a really low dose with a low-dose opioid, it tends to give the same type of pain relief that it would with a higher dose and not cause the opioid-induced hyperalgesia. So it's pretty interesting. There's still a lot of studies being done about it. It's used for alcohol cravings. It's used for a variety of things, mostly related to opioid and alcohol use. So what can we do? And I think we've already gotten to this point. I mean, I recommend we stop handing out gratuitous 3 to 4 Norco a day for things like treating prescriptions just to keep patients happy rather than healthy. This slide came from a talk I was giving to other physicians. I personally don't believe that Suboxone is a great long-term solution. It's trading one problem for another because Suboxone is very difficult to come off of, just like methadone. Patients need therapy and coping tools. They need better access to education. And people need to force politicians to mandate insurance cover a lot of these treatments, because the problem is we have them available, but they become unaffordable to people. And then somebody's there to fill that void, right? The drug dealers are there. They know where the drug dealers are, right? They're coming to you for a solution, and you're telling them to go back to the drug dealer. That's essentially what's happening. We have to disincentivize pharmaceutical companies with high taxes, fines. It's the thing about opioids, okay? No matter how much lip service is paid to getting opioids under control, et cetera, it is a huge cash cow. They could predict their cash flow for years at a time, and they can use that to securitize loans on it. For other projects, they're very reluctant to want to give it up. Okay, they're very reluctant to wanting to put limits on it, and you just have to think of the economics of the situation. There's a reason for that. Okay, and there's also a contentious issue with the pharma lobby being actively against any kind of regulations to opioids. They'll say, on the one hand, yes, we're for it, we want to try to control opioids, and we've got something called Suboxone, which we can sell to you in order to do that. There has to be some incentive to them in order to want to buy into all of this. So their incentive right now is being supportive of Suboxone. It's going to be a long-term problem which would take years to fix. Physicians have to stop prescribing narcotics for every headache, ache, and pain. Okay, I'm not saying that opioids aren't useful. They are. Okay, there's a place for them. But we have to be very careful and judicious in how we use it. To prescribe it appropriately, prescribe it to the right patient, and no extras to keep it home. I want to talk about this point for a second. We see in the past a lot of times where people would have a little supply at home in case they needed it. Okay, I don't know if you're all aware. I know this is an interactive session, but so I'm not going to ask you. I'll tell you. The number one place where opioids get from house to street is from grandma and grandpa's medicine cabinet. Grandkids come over the weekends or during the week, and they take it, and it's out on the street. So we have to be careful about that. So just enough to get them through the acute pain, and that's it. I was going to take questions, but I guess that's not now, right? Not now. Towards the end. Okay. There are a lot of other types of treatments. Dr. Chen's going to get into that. There are a lot of things that can bridge the gap between prescribing the right amount of opiates and taking somebody or controlling somebody's pain overall over time. There are a lot of adjunct treatments. There are a lot of injections, nerve blocks, which at least for now we seem to think are safer. And after, I would be more than willing to answer questions. Actually, that's what I'm good at. So look at that.
Thank you, Dr. Ananth. You helped us understand the relative difference in potency of opioids, how dependency develops, and how one can become desensitized with long-term opioid use. And our second speaker is Dr. Reuben Chen. Dr. Reuben Chen is board certified in physical medicine and rehabilitation, specializing in sports medicine, pain management, and cosmetic medicine. He leads the regenerative medicine programs at Pacific Pain and Wellness Group. Dr. Chen is one of the few physicians in the country who also performs and integrates medical acupuncture into his treatments. Since December 2012, he's been affiliated with Torrance Memorial. He also speaks fluent Mandarin, Chinese, and is a black belt in Taekwondo and Judo. Dr. Chen earned his Bachelor of Science in Neuroscience with honors from Brigham Young University in Provo, Utah in 2002. He obtained his medical degree from the UC Irvine School of Medicine in 2007. He also completed his postgraduate training in the Physical Medicine and Rehabilitation Residency Program at the University of Minnesota. Since then, he has founded the Sun Living Health and Wellness Center located in Torrance, where he provides cosmetic treatments and monitors weight management. In addition to this, he has had many years of medical acupuncture experience. Dr. Chen has undergone specialty training in various cosmetic programs such as Botox, acupuncture, and regenerative medicine. He's had experience in the use of prolotherapy and platelet-rich plasma for the treatment of pain and musculoskeletal injuries. His professional memberships include the American Cosmetic Cellular Medicine Association, American Academy of Physical Medicine and Rehabilitation. Please join me as we invite Dr. Reuben Chen to the stage. Thank you.
Hello. Hi, good evening. How are you doing? All right, so I got to do the fun stuff. So today, I'm going to talk about some of the things. Peculiar. Am I able to? What we'll cover today. Perfect. Okay. So we're going to talk about some of the treatments for not using opioids to help manage pain. Now, I'm going to go through this stuff. It's going to seem sort of like a lot. So afterwards, you can ask me any questions that I can answer. And if I can answer it, I'll respond. And if I can't, I'll make something up. But it'll sound really good, though, I promise. So the different things about how to manage pain, and Dr. Ananth alluded to it, when we manage pain, there's two different approaches. Some of the pain obviously could be physical, and we treat the injury, arthritis or something like that. Or it can be also when you have chronic pain or pain for a long time, we have to treat also the brain as well. This makes some people feel uncomfortable. Sometimes they go to the doctor and the doctor thinks it makes it sound like it's all in your head. Maybe the doctor also thinks that, and that's not necessarily true, but there are some changes that do happen in your brain once you've had pain for a long time. So I'm going to address some of the treatments for that. All right. So ketamine has a very interesting name for itself. It's used commonly in surgeries as a local anesthetic. It's a non-opioid. It has effects similar to LSD, except it's a pharmaceutical grade, so it's obviously better. And one of the things about ketamine that's very interesting, and it's always fun to see, is when we use it, people commonly have a little bit of a out-of-body experience so that their mind doesn't feel connected with the pain that their body is going through. So it can be used, it's been used for a number of different treatments. Dr. Ananth is actually very experienced in this to help with depression. It can also help with different, more difficult types of chronic pain. But it's a very, very interesting medication. There's still research going on about it. So it's very cool, and it's been around for a long time as a surgical anesthesia. All right. This here is one of my passions. So we talked about earlier that sometimes pain is definitely physical. You have chronic knee pain, your shoulder is given out. I had the unfortunate privilege to help my dad get x-rays of his shoulder to tell him that he probably needed to have surgery, and therefore he didn't listen to anything that I have to say after that. So, but one of the things about these things, especially with severe, maybe like more like mild to moderate arthritis, is that it can be treated with things like stem cell or PRP to help prevent further degeneration and potentially reverse some of the results of arthritic pain, of chronic pain. It does have its own limitations. So if you go to a place and somebody sells you some magic pills and say, this is stem cell and I cure everything in your body, don't listen to them. you should listen to me. No. But no, seriously though, there are limitations to all of these treatments, but stem cell, there's ongoing research with it. There's 3 different types that we've mentioned here. There's bone marrow, adipose, which originates from your own fat, and also taking out the growth factors from your own blood. It's a very, very fascinating area. It has a lot of potential. So if you have any questions about that, feel free to ask. This is another area that's very interesting as well, is something called transcranial magnetic stimulation. So I had mentioned before, when you have had pain for longer than 6 months, your brain actually creates a change to it. And it actually starts to think that that pain, that chronic pain, that long-term pain, maybe your back pain, is normal. That your body is supposed to be having that pain, and the brain gets used to it. So there are different techniques to help try to reprogram the brain, and transcranial magnetic stimulation is one of them. It's a very interesting technique. When I was in training, in the University of Minnesota, they had a machine there. It was enormous, and now it's become much more compact. And it's something that's used frequently for different things, not just pain, but autism sometimes, ADD, things that require maybe some slight alterations in the way your brain is thinking. It's very fascinating. Meditation, again, this is trying to change how your brain thinks. There are all kinds of ways to do mind-body. Meditation is one of them. These are common things you can get on apps. You can have a meditation coach. There's lots of activities such as yoga that do use different types of meditation. And meditation is great. I've seen it. My kids do meditation at school, which is great, I think. And for me, myself, I do at least 10 minutes of meditation every morning. It does help with focus. I know some of you probably are nodding your heads that you've done it yourself. So it's something, if you haven't started it, it's very good. And there's actually been lots of research that shows, as they quantify meditation, different ways that your brain does change over time. So if you do chronic meditation, your brain will alter as well and become used to it, just like if you had chronic pain, your brain gets used to that as well. So these are good stimuli that you want your brain to get used to. All right. This goes along with mindfulness as well. Ways to help with the brain. Different techniques. Meditation can be one. We're going to go over several of them in a little bit. One of the things, again, that I mentioned about reprogramming your brain with especially things like meditation is that you can help with your emotional centers. There are other things that are associated with chronic pain. You get anxiety. Frequently, there's depression. A lot of times people have difficulty sleeping at night, and these are things that with mindfulness exercises, you can help that process improve over time. Now, one of the things that it's a good thing is that these are things that you can do yourself at home. A drawback is that it does take time for those changes to come to fruition. It's not as much time as most people think, but it may take maybe weeks to actually feel the change. But I have a lot of patients, and change does come. Acupuncture, also, I guess you mentioned acupuncture a lot. I do acupuncture. It is a very good treatment. It is also, and I'm going to add this to my stem cell part, it's not a miracle, but there is a lot of research around acupuncture. Acupuncture, the mechanism of acupuncture is more well-known than any opioid because it's been researched so much, mostly because people want to debunk it. But acupuncture creates a very interesting effect when used with electricity. So at different wavelengths, it does travel up the spinal cord and can cause changes in the brain. So typically, there's been research that's shown that if you have good results after maybe 3 to 4 treatments, if you have at least 11 consistent treatments, that any changes that occur in the brain become permanent. So that's the benefit. If you've been doing acupuncture for a long time, many of you can attest to that. All right. Neurofeedback is also a very interesting treatment modality. We talked about transcranial magnetic stimulation before. That is what I would consider a passive treatment method, where something is affecting your brain and is eliciting a response in your brain. Neurofeedback is literally training your brain to think differently. They will typically, if you go to have neurofeedback training, they'll scan your brain and with something called a QEEG, and they evaluate the brain waves and brain function and compare it with normal people at your age. And any areas that are hot or cold, they use different, almost like games, to help stimulate those areas to make sure that you're in what we call the optimal zone. So it's mixed with sound, it's mixed with visual cues, and basically over a period of time, you literally teach your brain to think differently. It's a very, very popular tool. It was started, I think, maybe 20, 30 years ago for treatment of ADD, and now it's expanded past that for things such as anxiety, depression, some forms of autism, but not all forms, and also for chronic pain as well. Oh, I get a lot of questions about this. Okay, so THC, or marijuana, is something that is become very popular right now. Now, there are good and bad things about marijuana. One of the good things about it is that it's something new and it's not an opioid. Some of the bad things about it are that it's not very well regulated, and there's not a ton of research exactly how it does affect the body at certain dosages. For example, if I said you should take so much ketamine for a certain effect, that has been very well studied. I'll be honest, nobody has really done that research because for marijuana, partly because there is a little bit of conflict between the medical use and the recreational use. And there is fear that if there's some maybe too much critical research, that it'll draw back on the recreational use. But there is a lot of positive research about the physical use of it. Basically, what THC sort of is it has a very similar effect as other psychotropic medications. So it can have hallucinogenic effects. It has been used to treat post-traumatic stress disorder, has been used to treat sleep disorder and anxiety. There are good benefits from it. I just caution anybody that's using it to be aware that it's not well regulated at this time. Also, there is 2 different forms. Obviously, there's the smokeable form and the edible form. The smokeable form typically is the most commonly seen, but now people are using edible forms of THC. And usually when you eat THC, it gets processed in the liver and creates a different metabolite that ends up to be maybe 4 to 5 times stronger than the smoked form. So just be aware, if somebody gives you something to try out, sit down first. Okay, so the same thing. CBD is not THC. The effects are very different. Typically, people use this for sleep. It has some anti-inflammatory effects as well. There's obviously different sources of it from marijuana and from hemp. The psychotropic effects are not the same, and you won't get some of the hallucinogenic effects as you will from THC. It's become very popular. Here's a tip though: if you order some online, you have to make sure it is hemp extract and not hemp seed oil. Hemp seed oil contains no CBD, but it's high in antioxidants and it's generally a good essential oil. But you have to have actual hemp extract and for there to be quantified CBD inside it. The stuff that's sold on Amazon typically is hemp seed oil. That's why it's so cheap. So, careful about what you get on Amazon. It may not work. Cognitive behavioral therapy, along with our mindfulness training, is a great therapy. It involves communication with a qualified therapist, a pain therapist. They can help you with the process of dealing with the pain. Now, sometimes when we go to cognitive behavioral therapy, I know that some patients feel like we're giving up, and I disagree with that aggressively. I think that being able to train yourself to control your pain, for you to control the pain, is more valuable than me giving you something to help manage the pain. That way you are in control of your own pain and you have the skills to be able to manage it. It does take time. Cognitive behavioral therapy is something that does take time, but if you have a good therapist and you go through the course and you have faith that you can control your own pain, it can work very well. I would like to thank we had two interns, Christopher Lynn and Ariana, that helped us with the preparation. They're here right now and they're awesome. So Ariana is going off to medical school in, I don't know, like a week or something like that, to become Dr. Hagigi soon. So I want to thank them for helping us put this together. So we'll be over here for more questions.
Thank you, Dr. Chen, for sharing how one can remap the brain with the way it responds to pain and how chronic meditation can be a positive influence. Our final speaker is Dr. Miguel Bert. Dr. Gelbart has been in practice in the South Bay since 1976. He received his PhD from the University of Southern California in 1979 and has been a licensed psychologist since 1980. In his private practice, Dr. Gelbart works extensively with alcohol and chemical dependency issues. His practice includes working with family members affected by the problem, such as workplace stress and violence, relationship issues, sports psychology and performance enhancement, psychological effects and physical illness, anxiety and depressive disorders. Dr. Gelbart is the founder and presently serves as the executive director of the Thelma McMillen Center for Alcohol and Drug Treatment at Torrance Memorial Medical Center. Please join me in welcoming Dr. Miguel Bert.
Good evening. Thank you for coming. Appreciate you taking the time. Listening to what was said, it just means, I guess, I'm old. Anyway, so a little bit of what I'm going to talk about is repetitive, from particularly what Dr. Ananth said, and if it is so, I'll go through it pretty quickly. But as I was listening to him speak, I also realized there's nothing wrong with repeating some of the things that he talked about because of how serious and significant those issues are in our society. So again, a little bit about, I'm going to talk mostly about a little bit about the crisis, give you some data that supports and lets you be sure that there's a crisis. And then, my area of specialty is addiction. We get to see over across the parking lot at Thelma McMillen Center the people who are using opioids as well as alcohol and marijuana and other drugs we get to see them when they're in their, they've kind of gone out of control. So I'm going to try to spend a little more time discussing what happens to somebody and what to do about that. But anyway, again, opioid epidemic by the numbers, some of these things you've heard, significant, 130 deaths a day on the average. If you think of it, it's a moderate-sized airliner going down every day. It's pretty significant. 47,000, I can't read my, 47,000 people who die from overdosing. We have 81,000 people having heroin overdose. 11.4 million people misuse prescriptions, and so on. Again, there is definitely a crisis. Approximately 47,600 deaths a year. Actually, I think that number's low. The last ones I heard were more between 55 and 60,000. So more people are killed by opiates in a year than the entire Vietnam War. Again, to make things relative to how much of a crisis this is. So how did this happen? How did we get here? First off, we were kind of duped by the farm companies. Really were. We being the American public. When they came around, it was recognized that pain was a problem, and JACO, the Joint Commission, decided to make pain, evaluating pain and treating pain, an initiative for all doctors. And farm companies came in and said, hey, we've got these kind of pills, and they're really harmless. They don't hurt. They were telling people that without any data to support that. But they were telling people, for example, they said in a study in 1980, only 4 cases of addiction among 11,000 plus people were found using opioids. 4 cases out of 11,000. This is the journal article from New England Medicine, attesting to that. Again, what they found recently and why companies like Purdue Pharmacy are being sued in every state are they were providing this information without real data. In those days, back then, you could advertise to take Vicodin and to take Percocet and to take OxyContin, as you'll see here. This is as early as 2007 at a conference, and there's booths like there are in the back of people, a physicians conference, touting the benefits of OxyContin without any of the addictive properties. So there's a crisis being manufactured. Again, some of the data, 2015, 2 million Americans had a substance abuse disorder involving prescription pain relievers. Of 64,000 drug overdoses, 40% were prescription opioid overdoses. Every day, I said, 115 people die. Interestingly, as Dr. Ananth said, 4 out of 5 heroin abusers abuse prescription opioid first. So without a doubt, opioid use and abuse is a gateway drug for heroin. And as Dr. Ananth said, why? It's cheaper and easier to get often, and especially with the pendulum having swung to having prescriptions more difficult to get, lots of people are turning to alternatives on the street. And as he said, there's a lot of bad things on the street. Now, I do a lot of speaking, and one of the things I've made as a mission, and I'm really happy that Dr. Ananth talked about the fentanyl issue and crisis. I've worked myself with probably a dozen families who have lost family members to a fentanyl death in this general South Bay community. And the sad part is dying, of course, and the tragedy it goes. The other sad part of that is many of those people were not addicts. Okay, they were just going in the wrong place and buying the wrong drug. And as he said, when you're not an addict and you take a drug that's laced with fentanyl and you think it's an opioid, you don't have the tolerance to handle that. People who are drug addicts run to that place where that person got that drug because they want that high. But again, it's a very, very dangerous thing. As crazy as it sounds, I encourage, especially the young kids we work with, never, if you're going to take an opiate, take it from your parents or from a physician, preferably the other way around. But don't buy it in the street and don't buy it on the internet, because it literally will kill you. So what is... I think they put my slide in the wrong place. Well, I'll do this anyway. I may come back to some other data in a moment. So ASAM definition of addiction, ASAM is the American Society of Addiction Medicine, says addiction is reflected in an individual pathologically pursuing reward and a relief by substance use and other behaviors. Another definition that we use more is continuing to use a substance despite experiencing negative consequences. So if you have problems in your relationships, if you have problems in your work, if you have problems in your with the law, you're getting ticketed and arrested for drug-related offenses, if you have a problem with your health, people are falling down, breaking things, having concussions, and so on. And if you have negative consequences related to use, and then you continue to use, that's a sign of an addiction. Usually I have one. There's all kinds of questionnaires where you can ask people, 4 questions or 9 questions or 15. There's one really good question in terms of doing an evaluation. Is there anybody in your life who has a problem with any substance that you use? And if the answer is yes, there's probably a substance problem going on. Let me just gather myself here because they missed half my slides. But anyway, so how do you develop addiction? How does one get it? First is initial use. Somebody learns to tolerate the drug even though it doesn't feel good necessarily at first. There's two modes of people. Some people, when they take a drug, it's the first time it's like, wow, this is heaven. I've been waiting for this all my life. And we can even talk about kids. Sometimes they know, and that's that genetic part of addiction that's kicking in. Other people, as Dr. Ananth said, get sick, vomit, don't want anything to do with that drug. But in the initial stage, they try it again, and they learn to sort of tolerate it, and they begin to learn to feel better about it. We then come to regular use, the next stage. Person starts really actively seeking the drug, wanting it all the time. Your slides are probably not in relation to what's going on here, because I think, right? They are? Okay. Anyway, user actively seeks the drug, and then getting high becomes a preoccupation. The feeling that they get is what they're really looking for. Then comes early dependency, where people develop tolerance. Tolerance means in order to get that same feeling, you have to take more of the drug. And in order to get the same feeling after you take more, it wears off quicker, and you have to take even more. So you have to take more and more of the drug in order to just feel even. People later in their addiction are just trying to even themselves out as compared to just getting that initial euphoric high. And then there's an increased frequency and amount of drug use. And then finally is the complete dependency, where a person loses control, it's difficult to moderate or stop using. Key element of dependency is severe withdrawal when they try to stop, and often the only treatment they have, the only self-treatment they have for that withdrawal symptom is to take more of the drug, which, is necessary if they're not under, physician's care at the time. And then, again, as I said earlier, in dependency, there's continued use despite severe negative consequences. Again, let me use alcohol as an example of what I mean by negative consequences. Anybody can get a DUI, okay? You went to a party, you went to New Year's Eve, et cetera, did the wrong thing, didn't think you were drunk, et cetera. You go, you get a DUI. That in and of itself is not an issue of a drinking problem. Having a second DUI, you have a drinking problem. I have people, theoretically, somebody can come and have 2 DUIs, 1 DUI a year. Every New Year's they get a DUI. That's a drinking problem, okay? In reality, that's not what occurs to people. But the point is, if you have severe negative consequences and continue with the behavior, you have a dependency issue. Another way to look at some of this, abuse of a drug is maladaptive use to the point it interferes with health, job, school relationships, as I just said, and continued use despite negative consequence. And then this is just a repeat of what I just said about what dependency looks like. Iatrogenic dependency. That's really more related to opioid. Iatrogenic dependency is, opioid dependency is often considered iatrogenic dependency. Iatrogenic dependency is drug dependency that starts or is initiated by a physician. They're not trying to get you addicted, but you know, it's a well-meaning doctor using medication for a problem, and you may go down that road of dependency. As it said when we started, I'm the director of the Thelma McMillen Center, which is right next door here. We've been there 30 years. It's an outpatient alcohol and drug treatment program. And we have a lot of pain patients with opioid dependency. And there are two types. There are people who have been fringes of or actual addicts for many years. They've been alcoholic, they've tried different drugs, they stumbled onto they stumbled onto opioids, and now they have an opioid dependency. That's this section. And their treatment is pretty standard. And not easy, but we work with them all the time. Last several years is this whole other class of people who would never have a problem. They would not be dependent on drugs. They would not have an addiction problem. They hurt their knee, they hurt their back, they had some physical problem and became addicted to opioids. And yet they're in the same position as the people who have come through a road of years of addiction. And for those people who have this iatrogenic addiction, it's a very, very difficult situation on two levels. One, many ways they can't relate to the addict and abuser that we're working with. And two, they often have a problem. They often have a pain problem, different than the person who's doing it just for the euphoric feeling. So iatrogenic dependency is a big part of what the opioid crisis has developed. Oops. I'm going to go through this quick because, these slides are a little these are out of order from what I meant to present to you. The longer you use opioids, the greater the risk, and the risk seems to rise fast. These are interesting. I'm going to flip through a bunch of slides and mostly just look for the colors, but these are primary non-heroin opiate synthetic admission rates by state per 100,000 population, and the dark red, is kind of purple and red, together indicate the highest, like 40 or 5 or more per 100,000 people. So if you see in 1999, only about 5 states had 45 or had those figures. You go 2 years later to 2001, and you go to about 11 states having significant admission figures. You go through 2 years later, 2003, and you probably have about almost 40% or so of the country. A lot on the East Coast, you see. Not yet here. That's 2003. Oops. Go to 2005. Now we're at about 70% of the country in these high hospitalizations for opiate-related admissions. 2007, maybe 75 to 80% of the country. 2009, almost the entire country, is overtaken by this opioid crisis. And interestingly, I wish I remembered the figures, and I hope I don't speak out of turn, but a good friend of mine is the chairman of psychiatry at Cedars, and he was telling me they did a study at UCLA Hospital, and which is obviously a great hospital, of in 5 years, they looked at all the people that came in with a opioid diagnosis, a primary opioid disorder diagnosis. 5 years later, more than 60% of those people were not alive anymore. Now, that means opiates will kill you, and that also means there's not enough treatment for people that have an opioid problem. We talked about opioids deaths surging. As we say, I think this number is, 2016 has probably gone up to 60,000 now. Who does it affect? We have you can see the age ranges here, 12 to 17. 6% of the opioid problems are 12 to 17. The largest group is 18 to 25, and seniors are more, about 5%. I'm going to talk a little about seniors because I know we get a crowd here that is generally along that line. So among senior population, we have about 15% of people have abused prescription drugs. Skip that. You can't see it. The drugs they abuse, opioids, primarily to treat pain, also benzos, alcohol, and stimulants. What causes people to use prescription medication? Obviously chronic pain and illness. They stop working programs of recovery if they have it. Retirement, death of family members, loss of income, relocation, placement, or being in a nursing home. Can't see much of this, but these are the signs of drug problems. Poor balance, disheveled appearance, poor hygiene, reporting medications are lost. I know the physicians are very in tune with that now. You know, people who are drug problems will get a prescription. They can't nowadays probably even get that kind of prescription. But they used to be able to get a prescription, a 30-day supply, and then they'd do one of several things. They would call up the doctor and say, hey, I lost my prescription. I'm going out of town tomorrow. Or they'd say, they'd go to another doctor, which they can't do easily anymore because there's registries that tell the physicians who's using what. But they'd go to another doctor and doctor shop and try to get prescriptions from other people. Of course, as Dr. Ananth said, they'd steal drugs. He mentioned taking, the drugs out of the medicine cabinet. For teenagers, we have, again, at the Thelma McMillen Center, we have a teen program. The primary source for teen drugs are their parents' medicine cabinets. Probably don't do it now. I know it's happened to me. I go to the dentist, have a tooth pulled, they give me a 30-day supply of Vicodin or Percocet or something. I maybe take one and I put the rest in my medicine cabinet and never look at it again. But not literally, my teenager and my teenager's friends come in and look at it. And when they take 2 or 3 or 5 or 10, I don't know that because I'm not watching for it. So we have drug, I think in the back we even have drug give back programs, and we have lock boxes and ways to keep your drugs safe at home. So what do you do if you have a problem? And I'm going to talk mostly from a psychological and psychiatric side. But you get a good assessment, and you review what's going on. What are the presenting issues? And you review the history of the problem. How long has a person done this? And have they had attempts to stop on their own? Are there co-occurring disorders, which means do the people have depression, anxiety, ADD, other psychiatric kinds of symptoms that they're self-medicating with drugs just to get to numb the feeling? Do they have past trauma? Trauma in one's life that's unresolved causes a lot of emotional problems and often leads to drug problems as well. Very important for us to evaluate a social support system, meaning what's home life like? Where do you live? I don't mean do you have a nice home, but if you live next to a crack house, you're gonna have a rough time getting clean. That's significant because some people do have environments that are really negative for them, and then we have to take them out of that environment. So we develop a treatment plan. A physician evaluation is extremely important. MAT is medication-assisted treatment options like Suboxone, which we use in our treatment program, but it's also got problems of its own. Methadone is a form of medication-assisted treatment, naltrexone. So there are drugs on the market that help, but in and of themselves, they're not treatment for addictive problems. Making sure people get psychotherapy for trauma and co-occurring disorders, and evaluating social support systems. I'm not evaluating, sending them to social support systems. Like Narcotics Anonymous, NA is Narcotics Anonymous. There's a group called Pills Anonymous. By the way, most of these groups I'm talking about meet here either in this part of the hospital or over in the Thelma McMillen Center. We have 12-step meetings a week. But you don't have to go to AA type of meeting. There's smart recovery, there's refuge recovery. As long as you have a social support system, you can try to get off these drugs, but not everybody can. So what do you do if you're unable to stop? Well, the first row of treatment is an intensive outpatient program, which is what we do at the Thelma McMillen Center. And there we do individual therapy, family therapy, in lecture meaning education on what the problems are, 12-step meetings, exercise, yoga, mindfulness. A lot of the things that Dr. Chen talked about are components of our intensive outpatient program. We do drug testing to make sure people are accountable and teach relapse prevention. So it's an outpatient program. The benefit of that is people go to work, they stay with their family, they stay with their physicians in treatment, they get hooked into a good support system within the community. So outpatient treatment is really good if somebody can make it, but not everybody can make it. In other words, can make it means can they go day to day without using? And if the answer to that is no, we then look for more than an IOP, which is we refer people to residential care, some form of inpatient care for 30 or 60 or 90 days where they're living in a environment where their entire 24/7 hour day is structured and they're monitored. And for some people, they require that. And actually, some people require much longer than that, believe it or not. So that's it. And we'll take a break, I believe, and then take some questions.
At this time, we'll ask everybody takes their seats. We're going to wrap it up here. We have our set of questions that have come in, and I think Dr. Chen said it very well. There would be questions along the lines of marijuana and THC. I'll ask the question, and then I'll pose it to one of our presenters to follow up with the question. The first question is, can marijuana, THC, cause dependency? Will stopping it, it's two-part, will stopping its use cause withdrawal? Is there a panelist that would like to take that question? So the question was, can THC cause dependency, and will stopping its use cause withdrawal?
Good question. I'm sure, I think we differ, so I'm going to just jump in quickly. I can only go by experience, two things. Experience in our clinic, we have a lot of marijuana dependency. I'm not trying to do the old, 50 years ago, Reefer Madness movies, scare tactic. But same with, alcohol. There's nothing wrong with alcohol. Can you hear me or not? No. Okay, can you hear me now? Yeah. Okay. I'll start over, make it quick. I believe Dr. Chen and I may have some differences on that. Can you hear? It doesn't feel like it's on, and I'm practically screaming into this mic. Okay, better. I could hear it. Okay. We will have some differences. Perhaps. Maybe not, though. Not that much. Well, I guess what I was going to say is we certainly see marijuana dependency in our clinic and have for years. However, we see alcohol dependency, for example. Is there anything wrong with alcohol? No. If you're an alcoholic, you should not drink alcohol. Probably approximately 10% of the population. I'm sure the same is true with marijuana. Percent of the population that uses marijuana for whatever reasons will become dependent on the substance. Those people who do should not use marijuana. With the increase in legalization of marijuana, just by numbers, we're going to have an increase in the number of people who become dependent on marijuana.
I'm going to agree with Mo on this. My personal feeling about marijuana, there is a lot of research about it, how it helps with pain. But again, like he stated, alcohol can also help with pain as well. I don't know, my personal feeling, and this is completely personal, it's not held up by any research. I think that marijuana is probably better as to be looked at as something for recreational use and not for treatment of pain per se, because I feel that it does a disservice to marijuana itself. If you look at it as recreational use, then it can be labeled in the same category as alcohol, and people understand that alcohol needs to be used in moderation. The way that they have stated it is now that marijuana is good for everything, can shrink cancer, can make your hair grow, can do all this amazing stuff. And I think that there is a disservice to it. There should be limitations placed on it. But right now, the way that people look at it is it's all safe. There's nothing wrong with it, and that's not true. It can be abused. So I agree. People use it in moderation all the time, and I think that that's fine. But it is something that can be abused.
One thing we haven't talked about is, listen, if you're smoking marijuana, it's almost like smoking cigarettes, and those risks that come with smoking are going to be the same with smoking marijuana. So cancer risks are going to go up as well. May trade one problem for another.
I'm going to jump to our second question. Will stem cell or PRP help with neuropathy pain? And will it help with bone-on-bone knee pain?
Okay. And those are the hard ones. Hello? Okay. Does it help with neuropathy? It depends on the kind of neuropathy. If it's something like diabetic neuropathy, I have not seen good results from using PRP or stem cell. I know that there is some research out there that with the IV use of stem cell that it may help with nerve pain, but I've injected it directly on top of nerves, and it doesn't accelerate the healing as much as you hope it would. If it's maybe a localized nerve, then there may be some possibility, but generalized neuropathy, I haven't seen a lot of benefit. For bone-on-bone pain, so the best way for stem cell to help is for it to be maybe mild to moderate. Once it becomes bone-on-bone, it becomes more difficult. Some people do try it. If it does become bone-on-bone, there are other types of treatments out there. There's things called microfracture. Basically, what it is orthopedic surgeon will drill small holes into your knee, fill your knee with bone marrow. Usually, during that process, your knee is casted for about a couple months to allow the bone marrow to solidify. The stem cells that are produced during that time are not as resilient as your existing stem cells, but it's a very, very popular technique. There's other techniques out there. One a little bit more expensive, or a lot more expensive, is grafting on cloned stem cells, not cloned stem cells, but cloned meniscus or cushion into the knee itself. That they've shown that the viability isn't very good either. It just doesn't last as long as your existing knee. But yeah, bone on bone, it's tough. If you're not looking into getting a knee replacement, you might want to try these other methods like microfracture or transplanted stem cells from your existing that are grown in a lab.
Our next question is, can one become addicted to ibuprofen?
That's a good question. I have heard of it. It's extremely rare. So, for all intents and purposes, for the discussion today, I don't think that that's something the majority of us need to worry about. There are people who can get dependent, and it depends on their pain. Here's a good example. Is that better? Better. Okay. Here's a good example. Somebody who has migraine headaches or just regular headaches, chronic headaches, and they use ibuprofen every day. Well, they're now going to be dependent on ibuprofen. Okay. Are they going to go out and rob a liquor store in order to buy ibuprofen? That's addiction. Okay, and that typically doesn't happen. Okay. Now, when they start to cut back on taking ibuprofen, especially a person who's got migraine headaches, they start to get rebound headaches. So that just reinforces the dependency. But to become addicted to it, I doubt it would fit the classical definition of that.
Can medical acupuncture help with compression fractures, for instance, anywhere in the spine? like help with sciatica pain?
Yeah, acupuncture can help with sciatica pain. It can help with back pain in general. So the limitations, so the benefits of acupuncture depends on how long you've had the pain for. Acupuncture can help with, like I mentioned before, some of the rewiring of the brain, so your brain doesn't basically reconstitutes itself so it experiences pain a little bit more normally. It will not be able to heal a compound fracture or reverse actual physical damage in the body in that way. So if you're talking about chronic back pain, acupuncture can help. But if you are hoping that it will heal a certain area, there are some limitations to that. Like a compound fracture, unfortunately, wouldn't be able to do that. There's some research that does show it does stimulate your immune system. So some areas with inflammation may improve, but yeah, like a compound fracture wouldn't be able to help with that.
Really interesting point. There is evidence to show that chronic opioid use can lead to compression fractures. You want me to talk about that more? Well, what happens is basically there's a reduction in testosterone. If you've been taking opiates for a long time, your testosterone levels tend to be lower. As that happens, your bone density tends to go down as well. So it's not a direct causation, it's an indirect.
It looks like we've had a lot of folks with spine surgery. What are the best alternatives for pain and healing? So I think we're really looking at patients with Medicare. What are some alternative options they might have?
Well, I mean, so somebody who's had spine surgery, if they continue to have pain after the surgery, unbearable pain, things that interfere with your activities of daily living, one of the best options out there is something called spinal cord stimulation. And this is, I mean, I'm talking about when your back pain is so severe that you just can't accomplish all the things that you want. Spinal cord stimulation works by essentially hijacking the pain signal higher up and replacing that pain with something, with a sensation that's more pleasing. So basically it drowns out the pain signal. It doesn't get rid of the problem, but it masks the pain signal. There are a variety of, this is something that you do after everything else has failed. For example, if you've done facet injections, epidural injections, all that other stuff, physical therapy, mindfulness, all the other stuff. If all that other stuff has failed or hasn't given you the type of relief that you need, that's when you go on to the next step, and that's where it can help.
Another question we have is, my mother-in-law had very painful arthritis and took hydrocodone for years. She did not seem addicted. Is it possible to take opioids and not get addicted?
I think the physicians will answer. I can tell you from experience, I've worked with many people who take their opioids exactly as prescribed for a long period of time and have no addiction problem.
Yeah, I would also agree. A person who takes an opiate for more than 2 to 3 weeks is going to have some level of dependency. Even if it's a small amount for 2 to 3 weeks, when they stop taking it, they're going to feel something from coming off of it. They're going to feel withdrawal. That indicates these are medications that cause dependence. There are other medications out there that do the same thing. Benzodiazepines, stimulants. There are a variety of medications that we have that are controlled substances that cause dependency. There's a difference between dependency and addiction, okay? And a lot of times we confuse the two. Addiction tends to indicate aberrant behavior. For example, somebody is prescribed 2 Norco a day. They always run out 5 days early, okay? And they're calling in and they're saying things. I think they gave that example earlier, right? Where they've lost their medication. We've heard so many different ones, it's fallen in the toilet. I mean, none of the other medications do, but all the Norco always does. Okay. The dog ate it. I've had that happen before. What else?
One of the best ones was the police took it from me.
Oh, yeah.
Like, oh,
It was stolen out of my car. My car got impounded. The medication was in there. The only medication was in there was Norco. That's when you're talking addiction. Okay? Not the person who's taking their medication the way they're supposed to take it, and they never run out, and they're taking it as prescribed. So yeah, it is conceivable that there are patients out there that have been taking Norco for a very long time and are dependent but not addicted.
We have an individual who wants to find what foods may have dopamine. They like to juice and extract their juice from fruits and vegetables.
What do you mean by that exactly?
I think that
Because dopamine, it does provide good brain function. Are there any foods that you can eat that will help with that? Any type of I know you're not a nutritionist, but I could obviously Google it, but maybe someone in the audience here might know.
So foods with dopamine, that's an interesting one. So basically what you're talking about is any other natural products, right? So herbs, products like fruits and vegetables. That's an interesting question. I've actually never been asked that before. But there are some herbs you can look up. There are different types of herbs that you can get that do have some increase in dopamine, make people feel more relaxed. There's common herbs that are used to help manage anxiety and depression. They're not things that you could find at Target or something like that. Those are usually something specialty, so you'd have to go to it.
Some of the Whole Foods, they have really talented people that work there that are basically, that's their job. Is they've studied nutrition, they've studied vitamins and that type of a thing, and they have a good base to talk about. So maybe I should try that too.
Your body produces these neurotransmitters: dopamine, serotonin, norepinephrine, acetylcholine, and it needs to work all in concert with each other. You can't have just dopamine, you can't have just norepinephrine, you can't have just acetylcholine, you have to have all of them. And your body produces those in the appropriate amounts, with the exception of cases where somebody is deficient in one, for example in depression or anxiety, and then they may be low on one of
But
them.
how does sugar? We have so much sugar in this society. Everywhere you go, everything is sugar laced.
I'm going to have to think about that one, but that's a legitimate question. I'm not. Yeah, I'll have to go research that.
All these things
Yeah,
that you're talking about.
definitely.
our next question is related to acupuncture. So is regular acupuncture as effective as electroacupuncture?
So regular acupuncture versus electroacupuncture. So acupuncture actually, so if you get regular acupuncture from a traditional Chinese acupuncturist, the most traditional way to do it is once you insert the needle, you manipulate it the entire time. It can be quite uncomfortable. And so, but that is how it's supposed to work. So when you put in a needle, you manipulate it by twirling it. And what that does is that sends a signal up through certain nerves into your spinal cord, up into your brain. Now, to save time for the practitioner, what they started to do was add electrodes to the needles themselves to help that type of stimulation to the brain. If you go to see an acupuncturist and they apply the needles without the stimulation effect, I would say it's less effective, just because research has shown that stimulation is necessary for certain pathways to be activated. But if you use it, say, for musculoskeletal relief, just putting a needle in a location, doesn't even have to be an acupuncture point, does cause changes inside the body. So if you have shoulder pain, if you've got back pain, and you stick a needle there and you feel that there's a release, then that's also a benefit. But if you're talking about something for chronic pain, that stimulation is necessary for that signal to go up into the spinal cord to the brain.
Are nerve blocks or epidurals effective for back pain, for example, thoracic back pain?
The answer is yes and no. You do things as a diagnostic and therapeutic injection. Anytime anybody suggests that you have an epidural, what they're trying to do is they're trying to say, listen, we think the pain is coming from here, and based on your symptoms, this is the next best treatment. This is after you've tried physical therapy, medication management, and many times if the cause of the pain is inflammation mediated, basically in the epidural space where the nerves are coming out, then an epidural steroid injection, which is basically the injection of steroid into a location in and around your spine, then yes, it can be effective. Now, after the injection is done, you'll see if it worked or if it didn't. If you got some relief, they may suggest a second one. If you got no relief, they wouldn't suggest doing another one.
Dr. Gelbart, you might be able to help. This one is there an addictive personality type?
That's pretty clear that there is. And sometimes it's genetic, certainly is behavioral. But yes, there's an addictive personality. And it doesn't have to be to a substance or that is harmful or negative. In fact, people can be addicted to exercise. They can be addicted to Whole Foods, not the department, not the store, but good food. So there's lots of positive addictions. Sometimes even the positive ones have negative consequences. But yes, there are addictive personalities. When we work with drug and alcohol people with that problem, I could see their addictive personality in almost everything. Like, I'm sipping this drink for the last hour and a half. They would have been done in 5 minutes, easily. So everything they do is lots of and full. So even when they're recovering from their drug of choice, the addictive personality is still there.
This will be our final question of the evening. Can stem cells be used to rebuild discs in a spine? Yes.
I'm going to answer this with Dr. Chen. I have injected, we have.
Yep.
Yeah, we have injected stem cell and platelet-rich plasma into the disc. Now, the key thing here that I think I need to, and this is my viewpoint only, and I think you agree, but we don't see a lot of benefit from a lot of these umbilical, amniotic, and Wharton jelly type stem cells. The best stem cells that we see come from your own body, okay? Now, there are limitations to this. For example, if you're on particular medications, it may render some of the stem cell activity to be less useful. Now, the answer here is yes, it can help to rebuild the discs, okay, but it has to be mild to moderate loss. If you have severe degeneration or severe disc degeneration, stem cells tend not to be very effective. Platelet-rich plasma injected into mild to moderate discs, degenerated discs, also is something that's been proven to be very effective. It's been shown. It doesn't work in everybody, and you have to be off of anti-inflammatories. You can't be on any antiplatelet drugs, but there is a lot of there's a lot to say for it. A lot of research is going into it as well.
Yeah, I agree. It does depend on the severity. It's not a miracle, but it definitely can help a lot.
And I think that a lot of people get sold on if you have a really severely degenerated disc, a lot of people want to jump to stem cells, PRP, because they want to avoid surgery, and that's totally understandable. We get that. The problem is you're going to be doing stem cells and having surgery right after. Okay? You have to be able to inject into something which has a capsule. In a severely degenerated disc, oftentimes that capsule is completely gone. Okay?
I want to thank our panelists for speaking this evening, and I want to thank you all for your good questions and participation. This concludes our session for this evening, and we encourage you to stick around, ask your questions, and thank you for coming.
Thank you. Thank you.
Thank you. Good night.